At the time, I took my eye off the ball a little, obviously just entrenched in my career. And my oldest son and his best friend became involved with drugs, opioids in particular. The best friend died, and I don't know that we'll ever know what he died from, but because again, back then they weren't quite as diligent as they are today. And so my wife and I felt like we'd been blessed with time and resources. So we thought we would try to help locally on a small scale to help people struggling the way we were, but give them a resource. The problem was there was really nothing successful enough that we really wanted to affiliate with. So we decided, let's take a white piece of paper and look for the most evidence-based programs in the world, and let's try and build something around that. And so fast forward 14 years, and at the time we had built probably one of the largest opioid treatment programs, opioid detox centers in the world. We're in Des Moines, Iowa.
Ever wonder how AI can revolutionize healthcare and even tackle the opioid crisis? In this episode, Mike Vasquez shares his incredible journey from healthcare technology to an innovative approach to tackling the opioid epidemic. His insights are changing lives. He chronicles his success in his book, The Untold Story of the Opioid Crisis in American Healthcare. Mike, welcome to Bump in the Road. If you would, tell us your story.
Thanks for having me, Pat. Well, my career actually started in healthcare technology, and I was lucky enough to become the CEO of a company that built the first electronic medical record for hospitals with integrated AI that we took public on NASDAQ. And after selling that company to 3M Healthcare, I then took on a project where we re-automated Medicare Part A. And with real-time processing, we're able to have a major impact for about 1,700 hospitals in the U.S. I sold about 5% of that company to Mayo Clinic. Once Mayo Clinic puts their name on something, obviously every hospital in the country wants to have it. At the time, I took my eye off the ball a little, obviously just entrenched in my career. And my oldest son and his best friend became involved with drugs, opioids in particular. The best friend died. And I don't know that we'll ever know what he died from, but because again, back then they weren't quite as diligent as they are today. And so my wife and I felt like we'd been blessed with time and resources. So we thought we would try to help locally on a small scale to help people struggling the way we were, but give them a resource. The problem was there was really nothing successful enough that we really wanted to affiliate with. So we decided, let's take a white piece of paper and look for the most evidence-based programs in the world, and let's try and build something around that. And so fast forward 14 years, and at the time we had built probably one of the largest opioid treatment programs, opioid detox centers in the world. We're in Des Moines, Iowa, so it's not exactly resort beach destination country, but 80% of our patients actually came from California, Florida, and Texas, because of the unique methods we had developed in breaking down brain chemistry and understanding how you become addicted to opioids and actually how you discontinue using opioids. And because of that, we saw a large national audience. And so we grew very quickly. So it was a unique path for us because I was on a path in healthcare technology in that industry and completely for 14 years lived inside of an opioid detox center, dealing with patients, helping families, struggling with the same struggles that we had gone through so that hopefully their path didn't end the same as our oldest son's best friend. I will tell you today as we speak, almost 20 years later, he's doing fabulous and has really just turned his life around and is enjoying. So that's been the great story. So then what happened was with our success there, we felt we needed to take what we had built and actually put it on a larger platform because we just couldn't expand. We felt it should be nationwide. So we were approached by a national firm to integrate into their program. And so we actually sold the program in 2018, 2019 to a venture capital roll up out of Nashville. And I found myself in 2019, and obviously, as you know, coming into the beginnings of COVID with 100,000, hundreds of thousands of opioid data points, unique experiences, and obviously with a passion for healthcare AI, I thought maybe there's something I can do to even expand that experience we've had, that path that God took us on from my path early on in my career, and apply it to even a larger population. And so we decided one thing is that we knew treatment members, people had to actually go through the challenges, the terrible things you have to go through when you become addicted. So because it doesn't just start with you hearing about somebody being addicted to a drug, and opioids in particular. It starts with family abuse. It starts with financial disarray and careers just being thrown down the drain. There's not a person who walked into our detox center who didn't have lost hope in their eyes. There was, and I don't care who they were, I don't care what social economic background they were from. And so at that point, I thought, what if we could prevent this from ever happening? What if we could identify and intervene? And so using that experience that we had after over 14 years treating thousands of patients through our opioid treatment center, what if we could develop a technology that could actually identify that you're going to become addicted or dependent? At least it's going to impact your life somehow negatively. Identify that early enough that we could intervene and put you on a different path. And so right away we started searching, is that even a reasonable theory? Is that a thesis we could pursue? And so what we found was from research, 75% of people who entered our opioid detox center reported they started with a prescription written by their doctor and probably paid for by their insurance plan. So it was interesting that we thought if we were going to prevent it, we can't really use the patients as our indicators, because the patients, to be able to identify them as addicted, had to already become addicted. So instead, we saw the indicators of what if we delved into the physician's practice and prescribing patterns, looking at the patients who'd become addicted and what did the doctors do to get them there, and then identify those patterns inside of the doctor's practice so that we could say what your practice is doing is going to take this particular patient on a path to addiction. And how did we do that? We used the defining or differentiating indicator of the term called withdrawal. And withdrawal is where the body screams out that it says, I want an opioid because I'm being denied it. So either I'm late in getting my dose, or I'm entering a drug treatment center and obviously not being allowed to have an opioid. And the way the body responds to that denial is by making you ill. I'm going to make you nauseated until you give me an opioid. I'm going to make you ill, and I'm not going to let you sleep until you give me an opioid. So interestingly enough, then we identified that one of those illnesses, because we found also in our research that those illnesses show up 5 months before you actually enter full-blown addiction. And so by scanning medical records with AI tools, we could find these medical patterns that were telling us that you were on the path, because your nausea treatment didn't start until the first day of your opioid, till after your opioid prescription. We know that that's probably an indicator that you're on a path to potential dependency and dealing with opioid problems. How did we do that? How did we know that? Well, we could identify that the illnesses that I just described were indicative of a patient that was dependent in an opioid detox center were actually showing up in the medical record. So we built a tool that spidered through medical records and looked for those indicators and then identified those doctors. And you may be familiar with HIPAA, which is the Privacy Act for patient medical records. So we had a HIPAA hurdle that we needed to deal with. And we found that inside of every paid pharmaceutical claim is the physician who wrote the opioid prescription's national provider ID number, who the doctor was that was writing those prescriptions. And then our software was identifying the patient indicators that were telling us which patients were on a path to dependency. However, interestingly enough, we also discovered that the NPI number for that physician is not covered by HIPAA. So we could scrape it out and then build a model of the entire provider network for an employer, for an insurance plan, and show them where their weaknesses were in the provider's practice, not how they were practicing medicine, but in how they were following up and looking for these withdrawal symptoms because they weren't trained in that. There's no physician, a family practice, general practitioner, internal medicine doctor, because number one, there is no research in the US that supports a family practice doctor, internal medicine doctor, writing an opioid prescription past day 90, because at that point, it's ineffective. And you need to refer that patient to a specialist because what you're doing is not working. It literally is defined enough in the CDC guidelines that several states, here in Iowa in particular, the state legislature wrote laws requiring doctors to do these things because at the end of 90 days, opioids aren't being effective and you need to do something else. So at that point, we looked for those indicators and then looked for those doctors. And then by identifying those doctors, intervene to them to not get them to try to practice how to practice how they were change how they were practicing medicine, but to change how they were documenting and looking for indicators of the patient's response to that practice, how they were prescribing, and were they able to identify that? They don't have the tools that could tell you that the nausea didn't start till after the first opioid, but we did. So now we were providing them data that they never had before. And we've seen across, we have 1,700 employers right now utilizing our software to help prevent this progression inside of their insurance health plans. And across that base, we have 95% acceptance by all of the doctors who we've approached. And the reason we've had that high acceptance is due to the fact that doctors truly want better outcomes for their patients. And when they're made aware of a weakness or something they can do to get better outcomes for their patients, they embrace it. So I'll pause here a second to see if you have any questions. We covered a ton of ground in a few minutes.
Manny, what's the next step for doctors? I mean, if they see if this is showing up in the data, what happens to the patient next?
Well, keep in mind, we're using prevention. So it's a unique terminology I use that we're using retrospective data to get prospective action for the providers, meaning that the patients that we used was their historical performance. And those patients, if they progress to treatment, there's already safety nets out there inside of employer programs, drug treatment, employee assistance programs. And so we assumed those patients moved into those safety nets. We were focusing on trying to identify the doctors that were letting it happen, correcting it so that the next employee, the next patient who walked through the door didn't have to suffer with that. So we were retrospectively using the data to help find the doctors and what their current performance was. So it's sort of like looking at old baseball scores to see how the pitcher today is going to do, and then change the game based on that current pitcher today. And so that's really what we focus on, and we've seen great success. And we have a 12,000 member teachers union in Central Florida. We've been installed 3 years. We've reduced opioid withdrawal symptoms in the school district 70%, and the teachers still don't know we're installed because we've never called a teacher. We never identify a teacher because all we're doing is calling the doctors, and the doctors are making the changes. So the patients never know. They just know that they stopped because their doctor educated them uniquely to the risk of an opioid to verify, do you really want to refill this prescription? Because here are the risks you face if you do. Now, if you need it, go ahead. But if you really think you're in a period where you could get by with ibuprofen, physical therapy, other alternatives, let's switch to that. And so at that point, 50% of Americans who are posed that question, and there's 10 of these types of questions we interject into the practice, 50% of people will respond, you know what, I'm going to discontinue my opioid. I'm not going to refill my script because those alternatives do look like an alternative. The next month, 50% of the remaining people will discontinue. So that's just one example of 10 that we have the physicians interject into their practice questions that they pose, and they're called brief interventions in cognitive therapy, where the patient briefly is intervened on by the question posed by the provider to really reconsider and contemplate, do I really need this opioid? If I catch you early enough in your dependency path, you'll consider and decide that. If you've already moved into addiction, you won't. We've treated 10,000 patients. You won't listen to us. So we have to find it early at those early renewals where you're still going to consider it and contemplate it and make a change. So that's really what we do and how we impact it.
Does this have implications for other drugs?
I was just asked that yesterday in a meeting, and so I see the opioid crisis as I believe we start to provide solutions and deal with it. As you know, the government's interjecting 36 billion into opioid prevention and treatment because of these opioid settlements and other technologies, drug treatment. And I think probably the next drug behind it is going to be Xanax. Xanax is worse than opioids. I would rather treat an opioid addicted patient than Xanax. Xanax is the devil because you treat a Xanax addicted patient and they become an alcoholic. The side effect of coming off of Xanax is alcoholism. So it's just a dreadful drug to be on. So I think that's probably the next, what we'll call crisis coming behind that. And so we're getting ready. Our algorithm, we're adjusting to be ready for that. And the third one is alcohol. But the problem is we can identify providers in the opioid realm, in the Xanax realm, because there's providers prescribing it. Alcohol's a little different. We don't have a prescription. So we can identify the patients because of medical conditions linked to alcoholism, but we don't have an action item because we can't reach out to a provider. So it's a little bit of partnership then with the union, with an employer to take those actions because we don't have that point of contact, that thing that really gave us our idea, which was 75% of patients who start on an opioid start with a prescription written by their doctor. So that's kind of where we see it going.
Xanax is a pretty popular drug, isn't it? How big a market is it?
It's large, and it's actually CDC has come out with a guideline that you never prescribe Xanax with opioids because Xanax has a 5-to-1 multiplier effect if you drink alcohol. So what it means is if you have a beer, it's the same as having 5 beers. If you have an ounce of alcohol, it's the same as taking 5 shots. So it's not unusual for a Xanax patient that has a few drinks socially to actually black out and then do things, car accidents, other things that they don't remember because they blacked out. Because though they, in a normal social setting, they drank what seemed reasonable, but the Xanax kicked in and put that multiplier, put them into a realm that they never had dreamed of. And Xanax, as you said, it's a behavioral health drug that's being prescribed pretty widely due to anxiety and think of all the other stress and things that are going on in the country. So it's prescribed fairly widely.
Are you getting any pushback from Big Pharma?
I wouldn't say we're getting pushed. Of course, we're not large enough to where they're feeling what we're doing. And if you think of it, Big Pharma is really being challenged to find an alternative to opioids because of the addictive factor in them. So a lot of the research going on in Big Pharma is how do we find a pain management solution that doesn't have the addictive elements of opioids. So we haven't seen that pushback, but I'm sure someday it could be there. But we aren't large enough to, we're not even scratching the surface of what's being prescribed out there.
With all the data that you can scrape and analyze, are there any biological markers that seem to be apparent for a tendency towards addiction?
It's interesting you say that. There's always going to be that genetic piece of that, how I metabolize an opioid, because some people metabolize them more efficiently than others. Things, though, interestingly, that we found are not genetic as much as functional. So, for example, I'm prescribed 4 medications. So you have an opioid receptor in your brain. And the opioid receptor, the prescription is intended to get to that receptor and alleviate pain. However, there are other drugs which actually go to that same receptor and block the receptor. So if you take a certain drug first, and then take your opioid second, that first drug beats you to the opioid receptor, attaches to it, and blocks the opioid from actually being able to function because it can't attach to the pain receptor. What happens? The patient thinks, my opioid's not working, maybe I should take more. And so there's a functional process that needs to be looked at the same time. Then, different than the genetic side, is what I call lifestyle side. We really find that you become more addicted based on your sleep, activity, and nutrition. So people coming in, we find that it's really critical to get 8 hours of sleep, 30 minutes of activity, and balanced carbs and protein. The biggest question we got after 14 years from patients coming through our drug treatment program was, where do we buy our mattresses? Because they have never slept so well in their life. And so what we found is patients coming in, if you think about it, poor sleep creates stress, and stress creates that desire, that need to be, because you're not feeling satisfied in your life. And so all of a sudden now, if at the same time you have an injury and you're prescribed an opioid, you now become more susceptible to dependency on that to feel normal, because that's really the difference in an opioid. Opioid addicted patients use opioids to feel normal, not the euphoric effect that a typical drug addicted person would, cocaine, marijuana, other drugs, to where they do it for a euphoric or a party effect. This actually, opioids are being used at this stage to feel normal. And so that's when people actually, that's why only about 18% of people who need opioid treatment ever get it, because they go into these phases of normalcy, but it's when they're using. So it's very hard for me. Let's say today in our discussion, I was going to try and convince you need to go to opioid treatment. Well, in today's, where you're at right now, you don't need opioid treatment. There's no reason. Why would I ever think of that? However, 6 hours from now, let's say you were on opioids, and then you start to withdraw and you start to act out differently than you would normal, then you know that you have that anxiety, those illnesses, the things that I talked about. Now you want to talk about getting help. And so what happens is, the minute you take that opioid, 20 minutes later, you feel normal again. And so we have to catch you in that cycle where you've been denied the opioid, you've gone into withdrawals, and you don't have easy access to it, so that you're in that phase that I can intervene and get you the help that you need. So it's a very difficult process to get people who are addicted to opioids help, because of that cycle, because it's being used to feel normal, not being used for euphoric effect.
That's interesting. One of the things that comes to my mind is, for all the drug ads that there are on TV, why aren't there some educational ads about look for this, look for that, and talk to your doctor?
I think that's probably in the fine print. Have you ever noticed how the fine print scrolls across the bottom that you can never read?
I
It's
don't watch TV, actually. I gave it up a long time ago.
probably buried in those ads. So I always laugh when I see the fine print. There's 3 paragraphs. there's no way you could read, and it scrolls across. I'm sure what you just asked is buried in there somewhere.
Hey, as I get older, I can't read most of these labels. You know,
I hear you.
you bring up something interesting, though. You bring up, and you stress diet and sleep. Are there any holistic approaches to these issues that we should be looking at as well?
Well, the key thing we recognize that right away. So what we did was, as I've already said, we made sure that we knew coming in, you haven't had a good night's sleep in who knows how long. So we made sure that you could get a good night's sleep. The second is, we had personal trainers on staff, and we actually bought a local high school gymnasium. And so you had to, whether you're in a wheelchair or whether you're a 24-year-old football player, you had to spend 30 minutes to 2 hours working out every day. Now, working out may be just walking on a treadmill. It may be something simple, but more activity than you normally had. And then we had dietitians who built, and chefs who built balanced meals, so that you could start to rebuild your body, both from sleep, activity, and nutrition. So that then, as you recuperated, you could, when the body screams out, there's a neurotransmitter called an endorphin. And the body screams out if it's feeling stress, anxiety, pain, and that endorphin naturally satisfies that. And those things that I just described helps the body to start replenishing those endorphins. And if you're not getting sleep, activity, and nutrition, you really aren't replenishing those endorphins. So when your body calls out for it and it's not there, it looks for that artificial response or that artificial satisfaction, which is an opioid. So that's really how you get into the cycle of continuing to use the drug because you're trying to feel normal. Your body's not providing its natural response. So now you're finding an artificial way to do it.
And to some extent, the corollary for all of us is pay attention to each of these components because they do add up and they do matter.
Yeah, absolutely. I think it's some, so we find less addictive people that are healthy, working out, don't have stress in their life, so they're getting 8 hours of sleep. They eat balanced meals. Now you'll still see that unique athlete who will get addicted. We had a college wrestler come in, and it's just at that point it starts to what you alluded to earlier, genetics, to where they just metabolized opioids differently, and it allowed them to become dependent.
When you say differently, what does that mean?
So what happens is opioids will break down within 4 to 6 hours. And that's why if you've ever had a prescription for opioids, you'll notice it. It'll say 3 or 4 times a day as needed, but typically 3 or 4 times a day because the half-life of an opioid is 4 to 6 hours. And what that means is that the body metabolizes through the liver, breaks it down, and it loses its pain function ability, but it turns into a derivative. And that's actually when we built our laboratory. That's how we knew we could tell how long ago and what opioid you took by looking at certain metabolites, the elements that the opioid broke down into. And so your body handles that. So if you and I both ran a marathon and we got done, you'd probably recover faster than I would. And it's because of the way my body metabolizes the different elements just than yours does. And opioids are the same thing. Your body will metabolize through the liver, through how it gets through the pathways. You've got the blood-brain barrier, which really gets into the other things going on in the body as far as your neurotransmitters. And then all of a sudden, you become either addicted or you don't. And it's based on a mix of all that.
I find your model for physician education and intervention really interesting because I think too often there's been a flow from the doctor to the patient that's authoritarian in nature. Take this, here's your prescription. You walk out the door theoretically happy that you have something in your hand. But I think that the model that you've employed for education is really a different one because it empowers the doctor and it empowers communication with the patient.
And it does, the thing that's unique that we have pharmacists on our staff. We found we needed to have our own staff pharmacists. And that's the feedback we've gotten from our pharmacists, who all of them have over 20 years each of retail pharmacy experience, which means they spoke to doctors every day. And that's what they found is they're by just proposing an opportunity. So they're not trying to train the doctor in a new procedure, train the doctor in a new document. They're just saying, if we've done the legwork for you, if you implement these things, you will get that outcome. But you don't have to go through and learn behavioral technology techniques, brief interventions, cognitive behavior therapy, because by just implementing this, what are those things? Asking you for a drug screen, not because I'm trying to catch you with anything illicit, but I need to know as a provider, do you have the right level of opioids in your system? Because the way I've prescribed it, I need to know that it's having the effect I was expecting. So I need you to take what we call a therapeutic drug screen. 50% of people who are asked to take a therapeutic drug screen won't do that, but that's all we've asked the doctor to do. And under CDC guidelines, they should be. So we're not asking them to do anything unnormal, but we're asking them just to follow CDC guidelines. And right away, the doctor thinks, somebody's looking, somebody knows I'm not following this, so maybe I will comply. So all the doctor did on their side was start to ask the patient to do a therapeutic drug screen to refill their script. 50% of the time, they're asked to do a therapeutic drug screen. The patient will say, maybe this is a good time to stop because they just don't want to take a drug screen. The third thing is that you should have an opioid contract in the file because from a risk management aspect, you need to document that I've educated you on the risks of continuing this opioid. And here are the risks that you'll face. Here are the guidelines under which I'll refill this script. And here are the guidelines under which I won't. You sign it, the doctor signs it, and it goes in your patient chart. 50% of people who are asked to sign an opioid contract will say, I really don't want to do that. Let's switch to ibuprofen and I'm probably better now. And same thing as my point is that there is no research that supports a family practice doctor prescribing opioids past day 91. So then if I need to follow the guidelines, I'm not doing anything new other than I have to refer you to fill the script. We're at day 90. I need to refer you to a pain specialist because I technically shouldn't be still prescribing this opioid. And let me set you up with Dr. Jones. He's a pain specialist. Well, you know what? I really don't want to go to a pain specialist. I feel like I can probably get off of this. 50% of people will discontinue and at that point and not go to that pain specialist. However, you can think, as we've got put each one of these brief interventions in place, if the pain is that bad, none of these insurmountable barriers that they wouldn't do. If my hip really hurts that bad, I have no trouble taking a drug screen. If my hip hurts that bad, I have no trouble signing a contract. I have no trouble seeing a pain specialist. So the key point that I think that gets lost sometimes in our discussion with providers is we're not denying a patient ever access to pain management, but we're making sure that it's appropriately being prescribed.
What's next for you?
I'm not sure. I'm 70, so I think I'll probably get to a point where if this company gets large enough for a platform, I might take a little time and enjoy my grandkids.